abemaciclib does have the diarrhea toxicity that is not seen, generally speaking, with the palbociclib and ribociclib. Of course, it has less myelosuppression, so if patients have issues with bone marrow, then it's obviously a good option for them. But the abemaciclib, because of the everyday dosing, may have a greater role to play in some of the more aggressive disease. There's some subset analyses that suggest liver metastasis, short disease-free interval, where patients haven't had the most endocrine therapy sensitive type disease, like with palbociclib now in the PALOMA-3. The real benefit in survival was those who did have more endocrine therapy sensitive disease. So that's a question that's still kind of emerging, et cetera. But with the daily dosing and not needing to take the week off, if you've got aggressive disease in the liver that's really pretty explosive, then it may make some sense. Although we don't have some head-to-head comparisons, but for myself, that's where I do utilize it, and I find that it really is important for the woman to manage the diarrhea over the first month or two. Right. After that, it really does tend to settle down, and become 2-3 times a week type of thing. You need an Imodium. I find that the women kind of figure out how to self-modulate on the diet. They tend to eat smaller, frequent meals, not that much at a time, and not too much heavy, rich foods, which can cause more diarrhea. So gals just start eating a little bit more lightly, a little bit more frequently, and not as heavy. And they manage it, interestingly, quite a lot by diet in the first month or two, with some Imodium, on top of things. But we give patients so much information when they come to the clinic. Hey, we got the bad news. The cancer is progressing. We got the bad news. We got to change therapies. Okay, here's the list of options. Let's talk about the options. Here's what I think is best for you. Here's how you take it. Here's the side effects. Here's how we have to, it's a lot of information.
And that's exactly, those are great points. And prior to, as we discussed, medically integrated pharmacy team, we keep saying it over and over and over again. But what you just described to me was the importance of having a medically integrated team. And to help describe that even further is, you painted that picture very well. One thing that we do at our Ankota practices is, not only is there a teaching consent from the prescribers, like this patient is going to be on this therapy, here's some clinical benefit that we hope to expect, here's some side effects that you may be experiencing, but the oral oncology nurse down in the pharmacy, or the pharmacist down in that space, reiterates that same clinical message when they meet with that patient, not just for the first time, but on subsequent refills. And so there's consistency in that message and education, which is critical, that individuals in the medically integrated pharmacy understand the importance of the nuances of these compounds. You mentioned diarrhea, knowing that, guess what? It's probably going to happen. And guess what? It will probably go away. We need to get you through this window, and here's the window. And it's great that you know that as a prescriber and they've heard it, but you mentioned patients are overwhelmed. But if they come down to the pharmacy and they pick up their prescription and they hear it yet again from a pharmacist or a nurse, and then subsequent follow-up calls from the nurse, like, hey, you're on day 3. How are you doing? This is some of the things you should be expecting. Are you taking this to help you with that? These are the things that a medically integrated team does versus just filling prescriptions for the sake of filling a prescription.
Yeah, that's so good, because if people haven't really heard that and they're not prepared, either they'll stop it because it's too much, or they won't stop it because it's, and they just will tough it out, and they won't call, and then you've got real problems, you've got real toxicities, you've got emergency room visits on your hands, hospitalizations, et cetera, which can obviously happen with significant myelosuppression or diarrhea, et cetera. So the medically integrated pharmacy team keeps a list then of everybody they've prescribed these to. So there's a lot of coordination here, you know?
Yeah, exactly. Coordination is a great word for that. And that's what I think what we pride ourselves in. What I say to the Ankota members is, we're not here just to fill prescriptions. We're here to do more than that. If your job is to fill prescriptions, there's other entities that do that. But that's not us. What we're here to do is we're to take it to the next level by being truly part of that care team and to get engaged specifically within the EMR. If the EMR, the electronic medical record, is critical not only for the pharmacy team to understand the patient that they're going to be seeing or that they're going to be helping, but also communicating back to the prescriber that, hey, I just made a follow-up call and they're starting to experience this, or I think we may have some issue with adherence. This patient may not be a good patient for oral therapies because maybe they're not really good with oral therapies and adherence is a problem. Where maybe an IV therapy would be preferable, you know, even though it's not as convenient.